study is, I think, one of the first study which takes into account in the randomization also patient preferences. That's why it's called PREFERE trial. And very interesting to hear what he's about to say about this project. Thank you.
So thank you, and thank you for inviting me to bring some information about this so-called PREFERE study. Before I do so, I also would like to express my gratitude towards Franz Recker and this organizing team to invite me to this very impressive surrounding, and I dare to say that I'm deeply impressed by the open-minded discussion here between people who come from a very heterogeneous background. So let's go to the so-called PREFERE study. PREFERE stands for Preference-Based Randomized Evaluation of 4 treatment modalities in low and early intermediate risk of prostate cancer. It is a big project, and there are 2 principal investigators. One is Thomas Wiegel, whom you met this morning, and myself. It's based on the fact that our high standard guideline in Germany recommends to inform patients with low-risk prostate cancer about 4 potential treatment arms, namely operation, radiotherapy, seed implantation, and active surveillance. This recommendation is not based on the fact that we know that these 4 possibilities are equi-efficient. We simply know that all these 4 alternatives can prevent prostate cancer deaths in a substantial number of patients, but it is unproven whether one or more of these is superior or inferior to other alternatives, or if they really are equivalent. And this is the questions to be solved by this trial. So the basic hypothesis of this trial is that we will find no significant difference in oncological efficacy between these 4 alternatives, but we are pretty sure that we will find differences with regard to the influence of quality of life or therapy-related morbidity. The primary endpoint of the trial, and this is why it's a very long-lasting trial, is cancer-related death. Inclusion criteria are newly diagnosed, low-risk prostate cancer and early intermediate risk prostate cancer. So we accept the Gleason 7A, but to prevent patients from under-treatment, they also can be randomized to active surveillance. You have to keep that in mind. We limit the maximum number of tumor-positive biopsies to 30% of all biopsy cores, and we limit the maximum tumor size of the major tumor focus to 5 millimeters. So, to go forward. Exclusion criteria. I think the most important point is you have to keep in mind that the patients randomized for this trial must be suitable for all 4 alternatives in this trial. So we have a number of non-oncological exclusion criteria. Patients, for instance, with a too large BPH cannot be irradiated, and that is why they also cannot be randomized for this trial. Or patients with urinary tract obstruction also cannot be irradiated, or patients with a large middle lobe cannot undergo brachytherapy, and that is why all these patients are excluded for this trial. So this makes the selection of the patients a bit tricky. The trial started in 2013, and as tumor-related death is the primary endpoint of the trial, it's a long-lasting trial, so we expect the end of the trial by 2030. Yeah. The recruitment period is expected to be 4 years. I dare to say that it presumably will take more time, because we intend to recruit more than 7,000 patients, and if we can manage to do that, we presumably need more times than that 4 years. Almost 100 centers are presently open for patient recruitment, and the number of patients that we need is estimated to be around about 7,600. This depends a bit on the preference of the patients. We will see what this means. The protocol demands a minimum number of 10 biopsy cores during biopsy, and recommends a maximum of 18 biopsy cores depending on the size of the prostate, but we would not exclude patients who had more biopsy cores. There is a very, very common trend in Germany to make a 24, even 40-fold biopsy, and that is why we did not limit, we did not put an absolute number of positive biopsies into the treatment protocol. We decided to prefer a maximum percentage of tumor-involved biopsies just to take into consideration the very different biopsy standards between different offices or different departments. The trial centers need to have a certain qualification, so they must be able to offer all 4 therapeutic options by themselves or in cooperation with external partners. This is allowed. Yeah. The departments must have experience in the curative treatment of prostate cancer, document by at least 100 cases per year. They must document that they have at least 50 prostatectomies per year, at least 25 radiotherapies for prostate cancer, at least 15 brachytherapies per year, and the individual therapist must document that he at least did 150 prostatectomies, and he must have done these 150 prostatectomies in the technique that he intends to use for the study patients. So all techniques of prostatectomy are allowed, open, laparoscopic, robotic. But if you want to do a robotic prostatectomy in a study patients, you must document that you did before a minimum of 150 robotic prostatectomy cases. Furthermore, there must be experience in the conduct of clinical trials, of course. A very critical point is reference pathology. So when patients are willing to become randomized, their slides first go to certified reference pathologists. He must confirm that the patients or the biopsy fulfills the entry criteria, and only when the reference pathologist agreed, and then the final informed consent is done, and the patient becomes randomized. The patient is informed by video material, by written material, by oral information, and when he is willing to participate in this trial, he is first asked to undergo a standard 4-arm randomization, but to be as tolerant as possible towards the patient, he is then allowed to eliminate 1 or a maximum of 2 arms of the trial. This is why it's called preference-based study. As long as he still is accepting the randomization process among the remaining trial arms. So the trial is a composite of a total of 11 sub-trials, namely 1 4-arm trial, 4 3-arm trials, and 6 2-arm trials. And the case calculation of 7,600 is based on the estimate that roundabout 20% of the patients will be willing to accept the 4-arm randomization, at least another 20% accept 3-arm randomization. Now, in case all patients would be willing to undergo a 4-arm randomization, we would need much less patients, something like 2,000 to 3,000. And if all patients would only undergo a 2-arm randomization, we would presumably need more than 11,000 patients. So the case calculation that we have so far is a rough estimate, which is based on the assumption that we have around about 40% of patients accepting a randomization between the more complex parts of the trial. We do not compare simply prostatectomy with radiotherapy. We try to compare the whole complex of the treatment concept of the different treatment alternatives. So this includes also all the forms of secondary or tertiary treatment that the patient accepts. So it may well happen that operation turns to be superior to radiotherapy, not because of itself, but perhaps because secondary treatment options after surgery may be superior to the secondary treatment options after radiotherapy and so forth. And that is why this trial is so complex, and that is why we need this long-lasting endpoint, tumor-related death. We cannot work with a surrogate parameter in such a trial. Same is for the radiotherapy arms. This is open and this is brachytherapy. Again, secondary treatment options are part of the protocol. Active surveillance, we just modified the protocol, so all patients have to undergo a confirmatory biopsy now within the first 6 months after having randomized for the trial. This is after the experience of the PREOS trial, where we saw that around about 20% of the patients had to be actively treated quite early, and the hypothesis is that this is presumably because of a missed tumor foci during the first biopsy, and this is why the protocol recommends an early confirmatory biopsy for all patients, not only the Gleason 7A, but also the Gleason 6 tumors. So far, before we started, we had more than 100 commitments of centers to participate in these trials, and we summarized the patient numbers which they announced they could contribute to this trial. It seemed that there was no problem at all to complete this trial. It remains to be seen if this will really be the truth. We know from all trials that the early assumptions turn out to be a bit unrealistic. Yeah. So this is the situation in Germany at present. So the green flags are those centers who already started recruiting patients. Yeah. The yellow ones are open, and the blue ones are those who committed themselves to participate but did so far not complete all the regulatory prerequisites. So this is the development during the year 2013, from January to December to January this year. Open center means this is the other yellow bars. These are the centers which are able to recruit patients, and the orange bars are the number of patients so far recruited. So by yesterday, we had recruited a total of 88 or 90 patients. Again, the number of centers open and they recruited patients. The first thing that we learned, that the reference pathologists kicked out round about a bit more than 20% of the patients. Some for major mistakes, overlooked Gleason 9 foci in the biopsy, but many also for minor mistakes which will disappear on the long run, so they did not measure exactly, so the largest tumor focus was 6.5 instead of a maximum of 5 centimeters. So we expect on the long run that less patients will be excluded from this trial. But I think this is the first collateral benefit from this study, that we learned that if we want to start to treat low-risk prostate cancers in a more personalized, individualized way, we have to look more carefully to the histology. We need to stimulate the pathologists to describe their findings perhaps a bit more substantial way than they did so far, and we have to learn to communicate with the pathologists, certainly in a much more intensive way than we did so far. I think this is the last slide. This interesting thing in this project, it's a very huge project. So the projected costs are around about 25 million euro. Yeah? And the money comes, and this is the first time that this has happened in our country, from the insurances, yeah? From the public insurances, as well as from the private insurances, as well as by altruistic NGOs like the German Cancer Aid, who are just committed to medical progress, nothing else. They joined together to finance this study. It's also supported by the government. It's supported by the scientific societies like the Deutsche Gesellschaft für Urologie or the Deutsche Gesellschaft for Radiotherapy. So there's a lot of public pressure to the urological community to bring this project, which certainly has a considerable risk to fail just because of insufficient patient recruitment. But we are confronted with a substantial pressure to make this project to a success. Thank you.
Thank you. Thank you very much, Professor Stöckle, for this very nice presentation of your study. And I know it's just the beginning of a large effort. Myself and as ERSPC trialist, I know that you are just at the beginning of a very, very long way. But I am very eager to learn the results which will be coming The paper is open for discussion. Questions from the floor? Can you tell me, why did you decide to randomize patients up to 75 years of age in view of the SPCG4 and Göteborg trial? Wouldn't it be wiser to randomize men until 65 years of age?
There was much discussion about this, but the decision finally was just that the trial should reflect the treatment reality that we have in Germany. And there's this common consensus that curative treatment is justified as long as the estimated life expectancy is more than 10 years, and the life expectancy in our country, in yours even presumably more, is increasing so considerably that we expect in the course of the study that more and more patients at the age of 75 are estimated to have a life expectancy of 10 years. So we did not want to exclude all these patients to become treated outside of the trial. So we wanted to include as many patients who are treated anyway into the trial as we could.
Okay, thank you. Peter?
Michael, the PROTECT trial is scheduled to report out its first results in November of 2015, which is only about a year and a half from now. What if one of those arms shows significance? How will that impact your trial? So basically, everybody knows that's the next big trial to report out, and yours is not that different other than having a fourth arm.
Well, we have another arm then, the Radiotherapy, which is not in the PROTECT trial. As far as I know, the PROTECT trial did also not complete the complete number of patients they wanted to recruit, but I'm not sure about it. They did, yeah? But it is part of the protocol that we allow to modify the protocol when new data arise that enforce us to modify the protocol. So we did make a number of amendments in between. So we changed already the inclusion criteria, we changed the re-biopsy protocol for the active surveillance, and if the PROTECT trial gives us information that forces a modification, we will do so. And if the PROTECT trial would give final answers, the consequence could be that we even would stop.
The other question, how are you handling patient follow-up? Because patient follow-up is by far the hardest part of any of these trials. Is that centralized, or is every single site responsible for their own follow-up?
Every single site is responsible.
Further questions?
Follow-up is even done by the office urologist, but every single site is responsible to get the data source from the office urologist to the center. So
but my point is, loss to follow-up at 10 years is one of the most lethal aspects of a trial like this, and without expensive follow-up and tracking patients as they move out of Germany or retire to Mallorca or whatever they do in 15 years, which they do, if you have too big a loss to follow-up after 10 years, it almost negates the entire trial. So my only comment is make sure you have a lot of money invested in the follow-up, because it's critical.
We are not so anxious about this because our society is not as mobile and as fluctuant as the American society. So most German elderly patients really stay there where they always stayed. They are pretty easy to refine.
Last question.
I wouldn't be too anxious that we lose patients completely for follow-up.
Last question? Okay, then I have one last question. You have patient preferences. And how will you control if patients, let's say with slightly bigger cancers, more percentage in biopsy, would rather prefer, let's say, radical prostatectomy? How would you control for this, let's say, slight but perhaps decisive bias in your study?
Well, there is a stratification process also in the randomization process to try to keep the most important prognostic factors equally distributed among the trial arms. But as a consequence of this preference-based trial, you cannot absolutely exclude that some more favorable patients go more to this. But you can. The number is high enough to calculate this out.
But are you going to look for this?
No, we are aware of this problem. We try to get the best biometric competence that we could get for this trial, and we're confident if we can manage to recruit the 7,600 patients that we also can manage to get substantial results.
Thank you very much.